to do that? Okay, perfect. And now I will introduce our wonderful speaker, Rianne Booker. So she's a nurse practitioner with Alberta Health Services. She's also a PhD candidate at the University of Victoria in the School of Nursing. Her clinical and research interests include the integration of palliative care and oncology, sexual health and cancer, and advanced care planning. Rianne is the past president of the Canadian Association of Nurses in Oncology. So thank you so much for being here today, Rianne. We're so happy to have you. And I will turn it over to you.
Well, thanks, Erin, and hi, everyone. Thanks for being here today. I'm in Alberta, just like Brad. We've had snow here and ice and miserable conditions, but it's not bad. I know it can be worse. I will just share my screen. But it was tough leaving Toronto, Erin, because it was 18 degrees when I left, and I came back to my vehicle at the airport covered in a bunch of snow, and it was encased in ice, and yeah, I was wearing silly little shoes. Anyway, should know better, right? Okay, I'm just trying to share here. Let's get this up. Okay, can you see the slides? Okay, perfect. So thanks for the invite to talk today about cannabis and cancer. I was asked to do a similar talk at the the Canadian Association of Nurses in Oncology conference back in 2017 or 18, right around when it became legal. So I think it was 2018. It's been 5 years almost to the date. It was October 17th, I believe, 2018. And they asked me to do a talk, and I didn't know much about cannabis and cancer. I had never tried cannabis at all, recreationally or otherwise. And I was kind of skeptical about the use in cancer care. And then I started to look at the research, and I read an excellent book written by a palliative care doctor. It's called Stoned. The camera doesn't show it very well. There we go. It's a wonderful book. And I did a bit of a 180. So I'll share the experience here and some of the research findings and things like that with you. So I don't have any relevant disclosures. I've received some funding for my PhD work through nonprofit organizations and government organizations. Of course, don't make any changes to your medical regimen or anything like that without talking to your doctor or healthcare provider first. And there were some excellent questions that came through already about drug-drug interactions in cannabis. So that's really important. But I would say talk to your doctor or nurse about using cannabis if you have questions as well. So today I want to talk about what cannabis is, what the current indications are for medical cannabis with a focus in cancer care, and then talk about some safety considerations as well. So cannabis is quite complicated to understand, and we're only just starting to scratch the surface, really, of understanding how cannabis works in the body. The cannabinoid system plays a homeostatic role in various physiologic and pathologic conditions in our bodies, and there's an endogenous or a system that kind of exists in our body already. And that is made up of receptors and different ligands, so things that can bind to those receptors, second messengers, and different degradation pathways, so breaking down the cannabinoids. Cannabinoid receptors are ubiquitous. They have an estimated 10-to-1 preponderance in the body over opioid receptors. So that's kind of interesting. CB1 receptors are located mostly on neural tissue in the central nervous system, so in the brain, spinal cord. And then the CB2 receptors are located mostly in the immune system. And those are important things to know, because that means that the way that cannabis works in our body can impact different physiologic systems, and namely neurologic function and immunologic function. We don't, again, like I said, know a lot about the different receptor systems and things like that in the body. We're just starting to learn. But we know that basically a CB1 signaling mediates neuromodular activities, so nerve-related activities, and CB2 signaling mostly mediates immunomodulatory, so immune system activities. We have some endogenous or innate kind of cannabinoids in our system already, and that's called the two that we know the most are anandamide and 2-AG, and then we have exogenous or outside the body, and that can be pharmaceutically produced, and we have a couple of products that we can use pharmaceutically, or the botanically sourced, or the plant-based cannabis that people would know as pot or marijuana. Again, just to say a little bit more about the receptors. So here you can see ligands are the things that bind to the receptors. And once they bind, they cause a bunch of different activities. These are the two receptors we know most about, CB1 and CB2. And you can have the plant or the pharmaceutical-based cannabis bind to these receptors and cause different effects in the body. And again, just to say, we know most about these two receptors and the endogenous ligands that exist in our body. And then CBD and THC is the two best known, I guess, constituents of cannabis. But there are hundreds of constituents in cannabis. And sometimes when we want to know more about how a drug or how substance works in the body, if we block receptors, we get to find out different things. This was a drug that was on the market in Europe. It never made it to Canada. And it was a CB1 antagonist, meaning that it would block the effect at CB1 receptors, and an inverse agonist. Again, it's going to block the activity of CB1 receptors, and it was meant as a weight loss drug. So we know that cannabis for some people can stimulate appetite and help with weight gain. This drug was meant to help with weight loss. But what the people who used it encountered was unwanted side effects, things like depression, anxiety, nausea, and suicidality. So that means if we're blocking this receptor, we can cause those problems. Well, what if we add a ligand or a substance to that receptor that turns it on? Then we think that we can help reduce nausea, reduce anxiety, reduce suicidality, and things like that. That's where some of the research is starting to go. But to make the point again that cannabis it's complicated. So the most well-known constituents would be THC and CBD. But there are all these other constituents as well. So we've got our endogenous in the body system, the ones that we can make, the drugs, marinol and sesamit, and then we have the plant-based. But even within the plant-based cannabis, there are all these different constituents. So things like the terpenes and the flavonoids and different things like that. And we think that those other constituents probably play an important role as well in mediating activity, but we don't know for sure what they do. They're being studied, but we do know quite a bit about CBD and THC, and we're learning more every day, I would say. So when we talk about cannabis, as people probably have heard, different things. So indica, sativa, that's some people think that there are different species of cannabis, and other people think it's one species with a few subspecies underneath. But you will hear indica, sativa, ruderalis, or a mix of indica and sativa. And indica is thought to be more of a good option for relaxation. It's often described as creating a full body effect. And that often is because there's more CBD in indica, while sativa is more kind of an active experience and can be a better daytime option. And then the hybrid, of course, you'd have features or characteristics of both. But I think what's probably more important than sativa versus indica is knowing how much CBD and how much THC is in the product, because the CBD and THC produce different effects in the body. The strain is kind of like we have different brands of beer and wine, so growers can come up with different names for their products. So if you go into one of the commercially available retail outlets, you'll find that especially bud, like the cannabis bud, it has different names often. So things like honeydew, Girl Scout cookies, they're in Canada, they're not allowed to have names that might appeal to kids. So you'd be probably hard pressed to find these kinds of names, but they do have different names. And that's just reflective of the grower's name or different constituents that they choose. But that information is not as relevant. Again, it's more important to know more about how much THC and how much CBD is in the product. So we've got cannabis available in a whole bunch of different formulations. So again, probably what was most commonly thought of or known of is the bud that would be smoked. You can also grind it down or mill it, and that can be used in baking and cooking. Oils and tinctures, those things, tinctures, sometimes you can use them sublingually under the tongue. Different kinds of edibles and beverages, topicals, even creams and salves. There's illegal synthetics where people make illegal products like spice and K2. I would stay away from those because again, the product varies greatly in terms of CBD and THC content. And there's a whole bunch of other things coming out as well: lubricants, patches, gum, intranasal sprays, etc. Cannabis, because the cannabinoids are lipophilic, meaning fat loving. We need some way to extract the THC and CBD out of the plant, out of the bud, in order for it to be effective. And the best way to do that historically has been combustion, and that's why people smoke cannabis. And so heating to high temperatures will help extract the THC and CBD out of the bud. So again, people probably very familiar with smoking pipes, bongs, joints. More recently, we see things like vaporizing with vape pens, portable vape pens. You can have a volcano that's a vaporizer as well. That's more of a tabletop device. And then the oral route, the dabbing is a type of vaping using usually a very highly concentrated product like wax, shatter, or butter, where the concentration of THC is 90% upwards. So very concentrated, and users would use a modified water pipe, and the bowl would be replaced with a nail head and heated up with a blowtorch. So again, not what we would recommend using. It's very dangerous. People can get injured using that route. And again, it's very highly concentrated cannabis products. So we would not advise that people use that route. We have on the market a number of different pharmaceutical products. We used to have, when I started way back when as a nurse, we had dronabinol or Marinol as well, but we no longer have that in Canada. So we've got Sativex, which is a spray. It's this one in the middle here, and it's a 1-to-1 mix of THC and CBD. Each spray contains 2.7 milligrams of THC and 2.5 milligrams of CBD. And it's mixed in ethanol, again, because you can't mix cannabis in water. It's fat loving or lipophilic and won't dissolve. So that's a good option for people, particularly when people are in the hospital. We'll sometimes use Sativex. And then Sesamet or Nabilone is a synthetic THC analog. So it's pure THC analog. It doesn't have CBD in it. And it's effective, and we've used it mostly in the past for nausea for patients who are taking chemo or on chemo. But some people say, and especially people who've used cannabis in the plant form in the past, they say that these pharmaceutical products are not as effective. And that's because there's this, what they call entourage effect, where because like I showed you in that chart, the plant has so many other cannabinoids, the terpenes, the flavonoids, other constituents, that maybe those other constituents in the plant that we don't yet even really know about are contributing to symptom relief or user experience in some way. So Sativex itself does claim to have some more of that phytocannabinoid or plant-based product in it, but Nabilone or Sesamet wouldn't. It would just be purely synthetic THC. So I think this is interesting, and I've heard anecdotally from people that they prefer the joint option, smoking a joint, because it does contain the other constituents. But again, I'll get into why smoking is probably not the safest route of administration. So as I mentioned, heating cannabis up will help to extract out the THC and CBD, and smoking, I would say, is by far the most common route of administration. But the problem is with smoking is when we heat up a product like that to that degree, we produce all these other toxic byproducts. In particular, there can be things like tar, polycyclic aromatic hydrocarbons, carbon monoxide, ammonia, and all of those can be harmful to the lungs. So far, research shows, though, that even chronic users of cannabis who smoke cannabis don't have higher rates of lung cancer unless they also smoke cigarettes with tobacco. So it doesn't seem that the cannabis on its own is causing lung cancer, even when it's smoked. It can cause some chronic changes in the lungs, though. So we do tell people to avoid smoking if they can. The other issue with smoking is you lose 30 to 50% of the cannabis by side stream smoke. So you're losing some product that way. Vaporizing is thought to be less harmful because you don't heat the product quite as hot. So there's reduced carbon monoxide, but you can still have those polycyclic aromatic hydrocarbons being produced, and damage can still happen to the lungs. And so we don't recommend that people smoke if they can avoid it. There are other ways that are probably safer to use cannabis. A company in Israel is looking at, almost like we would use for asthma, these inhalers that are meter dose controlled. So people would put in a little cartridge, and it would have a certain amount of either THC or CBD or both. And then you would avoid the heat or the production of all the other toxic byproducts. So this is being studied in Israel, but nothing on the market, as I understand. I think this device did get Health Canada approval, but in 2021, but as far as I know, we haven't seen it yet on the market widely. And then oral consumption. So a year after the cannabis legislation was passed in Canada, edible options became available. So things like capsules or tinctures, oils, and things you can put under your tongue, cookies, gummies, mints, gums, beverages. You have the whole array of options here. And I think this probably would be the route we'd recommend most often for patients, and usually in the form of capsules, where we know that there's a certain amount of cannabis, so CBD and THC in the capsule or oil. Edibles are also an option. The tricky thing with ingesting, be it capsules or gummies or cookies or whatever it might be, is that everyone metabolizes things slightly differently. And when you eat something, you have to wait 30 to 90 minutes at least, and sometimes up to 4 to 6 hours before you'll feel effects. And so you'll have delayed onset of action of the THC and or CBD, and that can be tricky. So people can sometimes eat something and then say they're not feeling anything, and then eat a little bit more, still not feeling anything, eat a little bit more, and then all of a sudden, a few hours later, it hits. And so we have to be careful about just that delayed absorption piece or delayed onset of action piece. And then again, some of these products, we know oral ingestion, that route, we lose some of the active ingredient because the product goes through our body and then through the liver to be broken down. And so there's only bioavailability is quite poor, so 2 to 20%, which means we're going to lose some of the effectiveness potentially. This is very busy, but this is just making the case that there's rules now with edibles, and some of these rules are important. Well, they're important because they protect kids, especially, and pets, but it can be a little bit of an issue in terms of cost for patients, because each package of edibles now, with the exception of the capsules, you can buy a bottle of capsules that has 10 milligrams per capsule of the THC. But otherwise, the edibles have to only have THC, 10 milligrams of THC per package. So I'll show you what I mean. And this can get expensive. So this is a package of gummies. There's only 2 gummies in this. And I know by law, each gummy can only have 5 milligrams of THC, because this total package, the total amount of THC can be only 10 milligrams. There's no ceiling on CBD as far as I know, and no ceiling on the other constituents. But THC caps out at 10 milligrams max per package. So these cost in Alberta about $5 or $6 each. And if someone needs to use 20, 30 milligrams of THC to get effective pain relief, this can add up very quickly. So it can be a bit expensive. As I said, the capsules don't have the same regulation. They're in a vial or a bottle, and they can have more THC in the total in the bottle. But I'll show you what the issue is here. So packaging in Canada, it's required by law. It's got to be pretty boring. It's got to be very non-appealing to kids. This is Pop Rocks in this one. This is gummies in this one. But you can see if they didn't have these regulations, and it's still the illegal market, you can still get these products in Canada and the US. But the packages here look very much like popular products that kids might mistake for something that they normally take. Like this one, it's really hard to even tell. Jolly Rancher gummy sours, it looks fine until you see that it says medicated here, and there's a little cannabis logo here and THC here, but a kid would never pick that up. Same with Skittles. You can see the little green cannabis leaves, but again, I don't think a kid would necessarily know what that even means. So these can be dangerous. And as far as I know, they don't have the same rules with the 10 milligrams per package. So theoretically, these could have a lot more cannabis per package and could be harmful to kids or pets. Cannabis infused beverages, I will say, probably save your money on these. Again, it was really well described in the book by David Cassaret about cannabis, that we know that cannabis needs that something to extract the CBD and THC out of it. You can't just mix, a bud of cannabis in a cup of tea or water. It won't pull out the THC and CBD. And even in alcohol, you need 40 to 50% strength plus alcohol to be able to pull the CBD and THC out. So beer and wine are typically beer, 4 to 7% usually. IPAs can be a bit stronger, but wine, 11, 12%. So beer and wine-infused cannabis probably will not give you a lot of bang for your buck. Similarly, there's juices and pops and things too, that those probably wouldn't work. And David Cassaret and his friend actually did an experiment where they bought, they said 1,000 grams of marijuana of cannabis and put it into wine and let it sit kind of for a little bit. And then they drank most of it. And they said all that happened was they had a really bad hangover the next day, but they had no effects of the cannabis. And again, because wine is not strong enough to be able to pull the cannabis out, the THC or CBD. And so he did another experiment where he took cannabis bud, like in this glass here, and let it soak in vodka, which is higher, it's 40%, and let it soak for 2 weeks, and then strained it out and had effectively a cannabis infused vodka, which wouldn't taste very good, by the way. And the other way, of course, you can pull the CBD and THC out would be using fat. And so again, in the one image I showed where it was milled or ground up, the cannabis bud, that helps to maximize the surface area that's exposed to oil or butter. So then you could heat that ground up stuff in oil or butter and then strain it out. And then you could use that oil or butter for cooking or baking, and you would have more active CBD and THC in that product. So it's the same thing with topicals. I would say save your money right now. And I usually buy products to be able to show when I do talks for nurses and that, but I did not buy the topical cannabis because a tiny little jar of it was $40 some. And I know it's not going to be effective. And the reason for that is THC and CBD are very large molecules and they have difficulty permeating the skin. So they have difficulty going through the skin. So, we would need some kind of product that helped with absorption. And there, again, a company in Israel is looking at this. What they're working on is a permeation enhanced gel to help penetrate the epidermis. I mean, the goal with topical application is not necessarily to get into systemic circulation. That would be like into your bloodstream. But if you're having an achy joint or, maybe a bad hip or something like that, or back pain, you do want it to penetrate a little bit beyond the epidermis and into, a little bit deeper where that pain is, if it's muscular or even if it's joint pain. And right now, the current formulations on the market wouldn't really do that effectively. So just to know that there's some differences with taking cannabis. So again, smoking will be the most rapid onset of action. So within 5 or 10 minutes, smoking or vaporizing, somebody would feel the effects of cannabis. Those effects might last up 2 to 4 hours, and it's easy to then use. So if you're having pain, you can just smoke half a joint and maybe your pain is alleviated, and it happens within minutes. That's easy. You don't have to use the whole joint. By contrast, if you take a pill or eat a brownie or some gummies or something like that, you've got to wait at least 30 to 60 minutes, but up to 4 hours to feel any improvement. And then sometimes the effects of ingesting, so the edibles, can be 6 to 8 hours, but up to 12 to 24 hours. So that's difficult if you have to go to work or drive the next day. It's harder to adjust. So it's like our oral medications for pain. So sometimes if we give subcutaneous or intravenous or even sublingual opioid pain medications, people can feel those effects pretty quickly, as opposed to taking a pill of morphine or hydromorphone or something. You've got to wait for that pill to kick in. So that makes it harder to adjust dosing and things like that. These are the 2 pharmaceutical products we have on the market. Navalone or Sesamet is the pill that we sometimes use for nausea and vomiting. Same thing, it takes a little bit to kick in and can have a long duration of activity. And the spray kicks in pretty quickly. And again, depends on how able somebody is to hold it underneath their tongue, because that's where it gets absorbed. And fairly short duration of effects. So that can be a good option. The nabiximols spray, it's not always covered is the problem, and it can be expensive. So just a word about potency. Over the years, pardon me, the potency of cannabis has increased steadily. So, back in the 1980s, pardon me, so THC is often expressed as a percentage of THC by weight of the cannabis. And so back in the 80s, the percentage was in the neighborhood of 3%. And then now you can see it's upwards of, 14, 15%. And even some products now are 30% plus. And if you get something like shatter, butter, or wax, highly concentrated, it can be 90% potent percentage of THC by weight. So that's pretty intense. Now we've heard a lot in the media and other places about cannabis, and CBD in particular as being this kind of wonder option, wonder drug that can fix all these different things. And I think the good news is now that it's being studied, but the current indications where the research is the strongest supporting cannabis use would be for refractory chemotherapy-induced nausea and vomiting. So that means if you've tried other anti-nausea medications and they're not working, then it might be reasonable to try cannabis. Similarly, chronic neuropathic pain, so that's nerve pain, that numbness, tingling, burning, pins and needles kind of thing. That pain can sometimes be helped by cannabis, and in particular, it's the THC that seems to be what helps. Refractory end-of-life pain, I would say in palliative care and end-of-life care in particular, we're very open to whatever works. We're now starting to look at the use of psychedelics even in end-of-life symptom management. So I would say we're quite open there. If something's not working, hey, why not try something else? And then spasticity in multiple sclerosis or spinal cord injuries is another area. We have very limited or moderate evidence to support appetite stimulation or weight gain. That being said, I would say it's pretty low risk to try cannabis if appetite and weight are an issue. Some people are researching the use of CBD in particular for insomnia. Similarly, for anxiety and depression and post-traumatic stress disorder, we don't have any evidence yet to say that it would be effective as a cancer treatment, and I'll talk about that in a few minutes. So there have been, like I said, a few studies looking at the use of cannabis for, in particular for symptom management. And this particular study found, it was a systematic review, and it found that there's reasonable evidence that cannabinoids can improve nausea and vomiting after chemo. They might help with spasticity, especially in multiple sclerosis, and some uncertainty in terms of pain management. But if it is pain management, it's the nerve type of pain that it seems to benefit the most. Similarly, this Cochrane library does these big systematic reviews. I think it's funny in some ways. One of the authors' names is Stoner, and it's a paper about cannabis. But this one looked at nausea and vomiting, and they looked at 23 randomized clinical trials, and they found, you know, again, this was between 1975 and 1991. So we didn't have on the market back then the really good anti-nausea medications that we have now. We didn't have things like aprepitant, carnicitron, ondansetron. Those drugs were not available. And even though, you know, so it's tough to compare to what we're doing now for nausea control, because this study didn't look at that. And the authors of this study did find that there might be some benefit, but it would be pretty limited benefit, and it would be again for that refractory chemotherapy induced nausea and vomiting. So once we've tried other things, if they aren't working, then it's reasonable to consider trying cannabis. And this was another study. This study was done in Israel, and they looked at almost 3,000 patients with cancer that were using medical cannabis. Some were using medical cannabis, some were not. They compared to patients that were not, between 2015 and 2017. And they followed these patients for up to 2 years. And what they found was, so the patients, so this is blue is before treatment, orange is after 6 months of using cannabis. And so the people that had low pain, not a huge difference, that's not surprising, but the people who had pretty high pain rankings, so pre-treatment, you know, they're having pain scores of 8, 9, or 10. And then after using cannabis, you can see that their pain scores dropped a lot. And the same with kind of quality of life. So beforehand, you know, a little bit of an improvement, but the people, sorry, I was going to say the people whose quality of life was good before, they didn't really see a big change. The people whose quality of life was bad before, they did see, you know, it improved quite a bit. So, and then other symptoms that they looked at, you know, things like nausea, vomiting, sleep problems, weakness, fatigue, some of those symptoms improved as well. And then they also found that a lot of the patients were able to limit how many opioids and things like that they were using, and sedatives for sleep and different things. So the cannabis use altered their other medication use in a good way in some ways, but the authors acknowledged some limitations in the study. Part of the big issue was the further they got out from chemo and treatment, their symptoms were thought to improve anyway. So was it the cannabis that was helping, or was it just that they were getting further out from treatment and that was why they were feeling better? So it's probably a little bit of both, maybe a little bit of the cannabis, but also probably largely, I would say, the further they got out from treatment, the better they felt. So to date, the research that we do have says, cannabis might be helpful for chronic pain. It might be helpful for nausea and vomiting due to chemotherapy. And again, the spasticity, particularly in multiple sclerosis and spinal cord injury. But the evidence that we have so far is poor quality. We need better studies, and those are coming. So that's reassuring. Even for palliative care, this was CADIF that released this report in 2019 saying basically that more research is needed. We don't have good quality studies to say, yes, people should use cannabis definitively. But again, if something else has been tried and it's not working, it's worth a shot potentially. And then this question came up in the questions that were submitted before the talk. And it is something that all of us, of course, in the cancer world and otherwise, I would say, are very curious about is, can cannabis cure cancer? Donald Abrams is a medical oncologist from the States, and he's done a lot of talks on cannabis and cancer, and he's been very involved in looking at cannabis use in cancer for decades. And he suggested that we know some types of cancers overexpress those receptors. So remember those CB1 and CB2 receptors. Some types of cancers have more of those on their cell surface than other types of cancers. So could those CB1 and 2 receptors be a potential target, just like some of the other targets we have in cancer care? It's tricky. So this is the pathways by which cannabis might work. But the problem is, as you can see, there's both upregulating or activating effects that cannabis can have, and there's inhibitory effects. So when we're talking about growth of cancer cells, we want inhibitory effects. We don't want upregulating or activating effects unless it's going to activate or upregulate a pathway or a molecule that might help, kill cancer. But the point is, it's very complicated. There's all these different pathways. So we know cancer cell proliferation is a bad thing. Apoptosis is like a programmed cell death where the cell is going to die. So if we can increase apoptosis, that would be a good thing. So yeah, upregulating apoptosis with the blue arrows here would be a good thing. Decreasing the amount of blood vessel creation. The tumor cells will sometimes create their own blood vessels, blood flow, because they want to take all the blood and nutrients and things to continue to help their own growth. So if we can block angiogenesis, that can help. So just making the case that it's complicated. And so far, a lot of the research that we have is in animal models here. You can see this is in vivo. That means in the body or in the cells, but this is in animals, not in humans. And different, I have a slide here that will show you all the receptor upregulation in that as well. But again, most of these have been in, the studies have been in mice models. So these poor mice smoking cannabis, no, they wouldn't smoke it. But just to let you know that, yes, it's being studied, but right now the evidence is just not there. So I think I went over this already, but we're looking, like I said, at the use for palliative care, symptom management. Some people are also looking at anti-cancer activities of cannabis, and this is moving into patient studies. But previously we just really had data from murine models, mice models, and things like that. But I did have a slide previously that showed the upregulation in all the different types of cancers where they've studied this. So there is upregulation of CB1 in some cancers, and downregulation, so fewer receptors in other cancers, and CB2 too. So it's just very complicated. So the worry would be that in some cancers, maybe we can prevent cancer growth or control it with cannabis, but maybe that would act as a growth factor for other cancers. So we would not want to do that. It is, like I said, being looked at in humans, and in glioblastoma, this was a small study, a small number of patients. You can see 21 patients, and they were randomized to receive placebo or the cannabis spray. Sativex nabiximols spray. And you can see that survival did look like it improved in the patients who used the cannabis nabiximols spray. But again, that's 21 patients. So that's not the kind of numbers that we would say this is a clear answer for us in cancer care. And same in blood cancers, they're starting to look at the use of cannabis. And like I said, again, you'd need to know CBD or THC because they have different effects in the body. And we know that CBD can have anti-inflammatory, immunomodulatory activities. And so if we can use CBD to help reduce inflammation, that might be beneficial in some cancers. So cost is a real consideration because most drug insurance plans won't cover medical cannabis. If you have a prescription for medical cannabis, you can claim that expense on your taxes as a medical expense, which is not always the best option because you need to get to a certain threshold anyway with medical expenses. But cost can be quite an issue. And then there's different side effects that people should be aware of, drug-drug interactions, legal issues. So the cost again, and these are pretty old numbers, so I would expect the cost today would be even higher, but the spray, the vial is around $300. And Sesamit capsules are, this is Alberta information, but Sesamit capsules, the 0.5 milligram capsule is $3.40 each, and the 1 milligram capsule is almost $7 each. So that's pricey. Oh, I'm sorry, the spray, I exaggerated. I do have the number here from Alberta. It's $124.95 per vial, and that would get about 51 sprays. So it depends on how often someone is using it. So $125 roughly. Cost of the dried cannabis across the country varies widely. And then talking about harms, so cannabis is a drug. CBD and THC do affect judgment, and THC in particular can be psychoactive. But in terms of overall risk to user, to the community, cannabis ranks pretty low. Alcohol is the highest one, even above heroin in terms of risk of harm. But we do worry about particular considerations, and so we know from the data so far we are not seeing increased lung or head and neck cancers unless people are using tobacco concurrently. We don't know yet about the effects on all-cause mortality, on atrial fibrillation, potentially bone loss, mental health. There are some data and some anecdotal evidence that mental health can be an issue. We don't know about bladder, prostate, penile, cervical, and childhood cancers in cannabis and brain changes. There have been some studies that have shown brain changes. We do see there definitely have been documented issues, and there's evidence of harm for overall health effects, potentially in terms of driving, stroke, pulmonary function, cross interaction with other drugs. Psychosis, particularly if there's a history of mental health concerns. There is an increased risk of testicular cancer, impaired driving, brain changes, as I mentioned earlier, we can see, and then potential harms with use during pregnancy. And as you can imagine, this hasn't been studied a lot just because it's a bit of an ethical issue to study drugs in pregnancy. But we would caution people to not use cannabis when they're pregnant or breastfeeding. Young patients should not be using cannabis, especially regularly. That can increase the risk of mental health concerns. And also chronic use at a young age can lead to tolerance and addiction even. If there's history of schizophrenia, history of psychosis with recreational cannabis, we wouldn't want to use medical cannabis. If there is a compromised cardiac status, and so, again, higher doses can be related to cardiac events in some people. And if there is history of use, substance or alcohol use disorder, we'd want to be cautious. And then driving cars and operating big equipment. If there's low blood pressure, we would worry about making someone particularly sedated, potentially, or more drowsy. And then use of strong CYP3A4 inhibitors. And there's a question about Eliquis or Abixapan. Abixaban, Apixaban. There we go, third time. It's it used to help prevent clots and things. So a lot of people are on Eliquis. It's a common anticoagulant drug that we use. And CYP3, it's metabolized by this particular enzyme in the liver. So yes, I would caution people using cannabis and Eliquis, Apixaban. There can be some interactions there. Also, we've seen since legalization, there have been increased ER visits, and in particular mental health concerns, and hyperemesis. That's paradoxically where it can cause more vomiting, and it could pretty intense where users have a hard time even stopping the vomiting. And strangely, hot showers seem to help. But yes, we've definitely seen increased ER visits and things. Addiction potential is thought to be a pretty small risk, unless people start using when they're younger, and then chronic users who are using, daily or very frequently. And so when people go into hospital, if they've been using cannabis every single day and suddenly they're in hospital and they can't take cannabis anymore, there can be withdrawals. So sometimes we will bridge people with Sativex or Nabalone if need be. And now, of course, people can use medical cannabis if they're taking it, or even recreational. But you shouldn't. I don't think you'd be allowed to use recreational cannabis in the hospital, and you certainly can't smoke in the hospital. And then just being cautious. So cannabis, especially the plant-based version, can be associated with different contaminants. So for people who are immunocompromised, if they're on chemo, and especially bone marrow transplant patients, we know that there can be increased risk of fungal lung infections. There can be other things like spider mites, aphids, mildew, mold, bacterial contaminants like salmonella, and then fungi like aspergillus, which can cause very bad lung infections. And so the licensed retailers are supposed to be following certain Health Canada guidelines, and they are subject to inspection. So I would say if you're going to buy cannabis, to make sure that you do it through, a reputable retail source. E-Valley, or e-cigarette vaping associated lung injury. So a few years ago, we were seeing these increased cases of bad lung disease or lung injury in especially teenagers. And it was found that it was these THC cartridges that were being used in the Juul vape pens. There's a cool documentary on Netflix about this right now. But that was causing lung injury in teenagers and young adults, and it led to many deaths. More than 60 people died, young people died. So again, I would say if you're buying a product, to make sure you're going to a licensed retailer, because the issue with this case is they found that they suspect vitamin E acetate that was added to the cartridges, and that was not done by the makers of Juul. It was off market, so somebody else was making it. Driving, if this does become part of someone's anti-nausea or pain management regimen, we want to make sure that people have plans in place for driving to and from treatment or work or whatever the need be, because especially with ingesting, you can have effects of cannabis in your body for up to 24 hours. And also, if you are a passenger in a vehicle and you are smoking cannabis, you can be fined, because you are then essentially creating what is known as a hot box situation. Hot box is where, there's especially with the windows rolled up, all that side stream cannabis and exhaled smoke and all that is in the vehicle, and the driver theoretically can become impaired. So just be cautious with that. And travel as well. So again, if cannabis becomes part of somebody's treatment and symptom management regimen, but they're planning to travel, we have to be really cautious. Even if you were to go to the States and coming back into Canada, you could get in huge trouble. Even if you're using cannabis for medical purposes, you need a permit or medical exemption from Health Canada, not just a prescription or note from your doctor. You need a special permit, an exemption from Health Canada, to be able to take cannabis across the border. Oops. Oh, shoot. Can you guys see this? I'll just move it down. I got a little warning to authenticate my software update. They're trying to do a software update, of course, right in the middle of a talk. Yes, so as I mentioned, don't, even if you've got, you're using cannabis for legit medicinal purposes, you don't want to take it in and out of the country. And that would apply to other countries as well. You'd need to check with their legislation. So as I mentioned, there are interactions potentially with drugs, and some of the drugs that people on this Zoom call would be taking, because they're common drugs. THC does inhibit 3A4, and that is the enzyme that Eliquis uses in its metabolism. So, we potentially could be, depending on if it's an inhibitor or an inducer, or a metabolizer, we can either cause increased levels of whatever other drug someone's taking in their bloodstream or decreased levels. And we've seen this with cyclosporin and drugs used in bone marrow transplant. We've seen them end up patients with toxicity from other drugs because the cannabis inhibited the enzyme that the other drug used to break down. I'm almost done, I promise. I'll try to wrap up here quickly. The immuno-oncology agents, and again, if you think about it, CBD in particular being a substance that can cause anti-inflammatory or immune suppression. In some cases, we like that side effect. So if you have inflammatory pain, arthritis, and things like that, maybe reducing inflammation is a good thing. But with some of our newer immuno-oncology drugs like nivolumab, we want to help the immune system, so we kind of spur it on a little bit. And what these researchers found was that cannabis users had reduced response rates to this particular type of immuno-oncology agent. And similarly, this other study found the same. So this not a huge study. So cannabis non-users only 68 and only 34 cannabis users. And there was a variety of different types of cancer and different types of checkpoint inhibitors or immuno-oncology agents, as we sometimes call them. And what they found was the cannabis users had shortened time to tumor progression. And it was pretty remarkable. So I have the numbers in particular. Yes, the median time to progression, tumor to progression, was 3.5 months roughly for cannabis users and 13 months for non-users. And this did translate into impact on overall survival that was statistically significant for the people using cannabis. So what I would say to that is for people who are on, and I don't did it, oh, impact on adverse effects. So like you would expect, if we're suppressing the immune system a little bit, we're probably going to have reduced toxicity because that's how those immuno-oncology agents work. They're kind of stimulating the immune system to do its job. And sometimes it overshoots a bit and you get these immune-mediated side effects like colitis, skin toxicity, rashes, all these things. Pardon me, the cannabis users had reduced rates of these adverse effects, and that's not surprising. That's a good thing, but that reduced, effectiveness or reduced side effects. Also, they had reduced effectiveness of the drug. And that's not surprising because cannabis, particularly CBD, again, can suppress that immune system response. So in some cases, it's a good thing to suppress that immune system response. In other cases, we want it, like in the case with these immuno-oncology or checkpoint inhibitor drugs. Pardon me. So dosing is important, especially if someone's never tried cannabis before. We always say start low, go slow. So if that's inhalation, that would be one little short puff of a joint, which again, we don't recommend inhalation. For oral, starting with 2.5 to 5 milligrams, this would be THC content. CBD, we're not as worried about. It doesn't cause those psychoactive effects. Someone's not is likely to get high. Pardon me, I got a frog in my throat. So same thing with sublingual under the tongue, 2.5 to 5 milligrams. Liberal topical use, it says. I would say don't waste your money on the topicals just yet. Wait until they come out with something better. We need more research on what that right ratio is, what that sweet spot is. And I think it will depend on the type of symptom or issue we're trying to treat. So far it looks like more THC is better for pain. CBD, on the other hand, more CBD content seems to be better for inflammation, anxiety. But what's the right balance? What about the other cannabinoids that are in the plant-based, the joint-based version? What's the amount, the proper dose for each type of pain and symptom issue? I think it'll vary. Route of administration, right now, we're saying we try to advise people to not smoke if they can avoid it. That would be preferred. I do have a wiener dog that looks just like this, but this is not Jasper. Jasper does not smoke pot. That was a stock image. So yes, just to sum up, just to say, I don't think that cannabis really is indicated for first line therapy, but if you've tried something else and it's not working, or if you think you can get better symptom management, it could be something we could add on, particularly for nausea and vomiting and neuro or nerve type of pain. Appetite stimulation, I don't think it's a bad thing to try. It doesn't always work. But again, the risk with using a small dose, small amount of cannabis would be quite low as well. I think it's really critical to find out how much THC and CBD your product has before taking it. It's very hard to read. Whoops. But on the package, it does say, this package says THC per unit, 5 milligrams. And I know that there's only 2 gummies in here, so they can only be 5 milligrams each. But you want to know how much THC is in the gummy, the product. And ideally, especially if you're a new cannabis user, using a little bit of CBD with that THC will help to ensure that that psychoactive or high isn't quite as high or intense. CBD really helps to kind of balance that out a little bit. So I always tell patients, especially if they're new users, start with a low dose, so 2.5 to 5. So that'd be one of these gummies would be 5, and try to have something that contains some CBD in addition to the THC. So there's other products. Sorry for the noise. I'll just show you. So I meant to show this as it's going along. That's what a joint would look like. So one of these joints, and again, by law, the package has to say what's in it. And this is a 1 gram of cannabis, and it's the sativa kind. It does not tell me how many milligrams specifically of, oh, no, I lied. There it is. It's very small. So there's 12.25 milligrams of THC in this. So for someone to smoke this whole joint to begin with would be quite a bit of THC. Remember, we said to start with 2.5 to 5 milligrams. So even just half of this joint would be probably more than enough. And the others, like there's all kinds. This is an example of a vape pen, a disposable vape pen that you can buy at the cannabis retailers. Looks like this. So that's a vape pen, disposable, one-time use. And it has in it 800 milligrams of cannabis in total. Sorry, of THC in total in this whole vape pen. It's got 800 milligrams. So if someone was to smoke this entire thing, that is a lot of THC, 800 milligrams of THC in this. So you would only want a few puffs of this guy. And yes, smoking or vaping, not advised, but eating or ingesting edibles, we have to just be cautious about the variable absorption. And it's really important to keep track of a symptom, of your symptoms. And I say this to anybody, it doesn't matter if they're using cannabis or not, but using a symptom journal can really help. And then when you go in to see the doctor or nurse, you can say, oh, on this day, this was 5 days after my chemo, these are the issues I had. Otherwise, it's kind of hard to remember on the moment, on the spot. This is cookies and cream chocolate cannabis, and it has 10 milligrams of THC in the whole chocolate, and 10 milligrams of CBD. So that's a 1-to-1 balanced. So for somebody brand new to it, you could cut it in half and eat half of that, and then you have to wait for 30 to 60 minutes at least to see how it affects you. And always make sure you store cannabis products out of reach of children and pets. These things are quite hard to open up and get into. They've got like a, almost like a Ziploc bag has, and it's quite tough to get into. But of course, we know our kids are pretty industrious, and they could just take scissors and cut that open, or pets could chew it open. So we'd want to be careful about that. There's lots of great resources out there, some really good videos. And of course, I'll send these slides to Erin, and she can forward them on to you. And I'm happy for people to email me as well. If you don't want to ask a question while we're here, feel free to email about this or any other topic. The previous talk was sexual health and relationships, but feel free to email me anytime. And yeah, I'll just take another look at the questions because I want to make sure we covered everything. So best time and dose to use cannabis for sleep and anxiety. I would use, again, something probably that's got more CBD in it. And so again, there's not a ceiling really on the CBD content. It could be 5 milligrams, 10, 20 milligrams even. And so if you're new, again, start low. So between 5 or 2.5 to 5 milligrams. But it would be for sleep and anxiety, something with more CBD would be better. And taking it probably, depending on when you go to bed, 8 or 9 in the evening. If you're ingesting, remember you need up to, 60 to 90 minutes before you have that effect. So if you're smoking it, it's going to kick in right away, 15 minutes. If you're eating it, so pills, capsules, oils, edibles, you need a bit more time. So depending on when you go to bed, you'd want to plan accordingly to give yourself, 60 minutes, I would say for sure, to see if it affects, or to give it time to kick in. Cannabis, yes, does cause apoptosis in some cancer cells, in some cell lines, particularly. These are most studies, but it doesn't always in all types of cancer. So we just don't know yet. So cannabis for a cure or treatment for cancer, not right now. We don't have the evidence. Drugs like Eliquis. So potentially, because cannabis, THC can be metabolized through cytochrome P453A4 is the enzyme that it uses. Eliquis uses that same enzyme. So I would just say be cautious and spread them apart in terms of your use. Take the Eliquis in the morning and maybe the cannabis later in the day, but just be cautious. And with Folfox in particular, no, there's no known interactions. So that's a fulfurry, oxaliplatin, and then usually the little baby bottle of 5-FU. No known interactions, but they haven't really studied it a lot. So I would just be cautious and use low doses. Safe for liver and pancreas. Yes, there can definitely be stress on the liver and pancreas with the chemo and other treatments. We wouldn't expect that the cannabis would put much more stress on your liver than say like a Tylenol. So many drugs, a good majority of drugs are metabolized by the liver. They're broken down by the liver. But this wouldn't be expected to put much more strain on. Now, if you're smoking it, it'll bypass that, the first pass metabolism in the liver. It'll still eventually, some of it will get broken down in the liver. But yeah, the answer to that is no. It wouldn't expect to be putting a lot more stress on your liver or pancreas. Sativa versus indica. Remember, indica is more kind of calming, more sleepy, more for nighttime use. Sativa more active. But again, looking at the THC and CBD content is probably the most important. Can it be used to increase appetite? Yes. And for some people, it works really well. It's just kind of hit and miss. And again, I don't know the right quantities of THC or CBD that are involved in appetite. So you'd want to definitely try to start out balancing the two, THC and CBD, and see how that goes. And then generally gradually increase from there. And then chemo brain, cannabis can make some people drowsy, especially THC, high CBD and THC contents can sometimes make people feel drowsy. Other people, they feel more active. Again, depending on the strain and the type of CBD or the amount of CBD and THC. I would say at this juncture, there's no evidence to say that it would help or hurt with chemo brain or chemo fog. Hopefully down the road, we'll have better options for chemo fog, because that is a very common, persistent, and can be long lasting for some people and very distressing. But for now, I would say it probably won't make a difference with chemo fog, except that it could make you feel more drowsy potentially. So those are most of the questions, or I think those are all the questions, but happy to answer more questions if anyone has any.
Yeah, feel free to unmute yourself or write it in the chat, whatever you prefer.
No, the only thing when you're first, so that's fine. Hydromorphone works differently. That's an opioid type medication. The only thing I would say is for the first couple doses, until you know how your body will react, make sure that you don't have to drive. Make sure you're somewhere safe. So preferably at home with somebody else with you. And, again, for some people, it can make them feel more drowsy. If you are tolerating that hydromorphone well and not feeling super, super drowsy with it, then it shouldn't have any adverse effects that way. It won't interact specifically with the hydromorphone, but it can, again, make some people more drowsy. So just be cautious with that. Yeah, so gabapentin's a great
Mm.
one for nerve pain. And it also can make you feel sleepy and drowsy.
Yeah.
And I don't know how often a day you're taking it. We can before bed, and then we increase to 3 times a day. So again, using it with gabapentin can make you feel more drowsy. So just be
Okay.
careful, so that you're not at risk of falling or anything like that. Yeah.
All right. Well, thank you so much, Rian. That presentation was amazing, so informative. I learned a ton that I'll definitely pass along to patients. And thank you so much for being here again today for another Saturday. Very much appreciate it. And thank you everyone so much for attending. It was great to have everyone here. And if anybody does have any questions, feel free to email me, Erin@craigscause.ca. It's ERIN. And I can pass that along to Rian and get some answers. And yeah, thank you so much.
Thanks, everyone.